everyone, and welcome back to Module 2 of Chapter 5. So I know I mentioned I was going to record these right after the first one, but I did wait until the next morning. Unfortunately, I'm still not feeling great, so I'm going to try to power through these next two modules. As I did mention in the first module, the second and third module for this chapter are much shorter. And then by the time I get the second and third module recorded and uploaded, which will be by the end of the day today, we'll have all our material ready for up until after the break next week. So, this is Chapter 5, Consciousness, and Module 5.2 is called Altered States of Consciousness, Hypnosis, Mind Wandering, and Disorders of Consciousness. So that's what we're going to cover in this module, and then Module 3 is going to talk a bit about psychoactive drugs. So first we're going to talk about hypnosis. So hypnosis is a procedure of inducing a heightened state of suggestibility. So a lot of the media portrayal of hypnosis is kind of being like a trance or like a very altered state in which, the person will do whatever you ask them to. But in reality, it's just kind of a more heightened state of susceptibility than one is usually experiencing. So participants try to alter their cognitive processes in accordance with suggestions of the hypnotist, and they usually report that their responses feel involuntary. Hypnotic suggestions are usually most effective when they fall into one of three categories. So ideomotor suggestions are basically specific actions that the person is asked to perform. For example, quack like a duck. Challenge suggestions would be basically saying that there are actions that cannot be performed. So for example, telling the person under hypnosis that they can't talk or that they can't move their arm. And then the cognitive perceptual suggestions would be either asking an individual to forget or remember specific information or to experience altered perceptions. So for example, pain reduction. So I believe I mentioned back in the memory chapter, we definitely can't really recover memories through hypnosis like some would suggest. But definitely hypnosis can at times be effective for things like pain reduction, or at least, helping people alleviate some pain and some physical symptoms. So because the use of hypnosis is so widespread and for such varied purposes, it's important to note what the major research findings do say about what hypnosis can and cannot accomplish. So these are some findings from an older copy of the textbook, but I find that they're really important to discuss when we talk about hypnosis. So major research findings have indicated that hypnotic responsiveness depends more on the efforts or qualities of the person being hypnotized rather than on the hypnotist. So basically it has a lot to do with kind of how suggestible the person is and how receptive they are to the idea of hypnosis. That is actually far more important in determining whether or not somebody will kind of be susceptible to hypnosis or responsive to hypnosis than the actual qualities of the hypnotist themselves. So it's a lot more to do with your expectations. The second is that hypnosis cannot force people to do things against their will. So despite the fact that people sometimes kind of talk about feeling like they were out of control and they had to do whatever they were told, they won't do anything that really strongly goes against their kind of personal beliefs or morals. The third is that hypnosis cannot produce feats that couldn't be done while not under hypnosis. So again, a lot of people talk about these extraordinary events and things that they're able to accomplish under hypnosis that they never would have been able to do otherwise, and that's not accurate. All of these feats could have been produced in kind of a normal circumstance, basically like with a rush of adrenaline or something like that. So they're not doing things that would otherwise be impossible. The fourth is that hypnosis does not increase memory accuracy, which is closely tied to the fifth finding, that hypnosis does not produce flawless re-experiencing of past events. And this is very important because, again, when we talked about memory and we talked about testimony, in court and things like that, it is very important to note that even though people may feel like they've kind of recovered repressed memories through hypnosis, this does not mean that those events are always going to be accurate. It doesn't really produce that flawless re-experiencing of what happened, and in a lot of cases, unfortunately, could be highly susceptible to kind of leading questions and things like that. So we shouldn't really trust the accuracy of memories that have been recovered through hypnosis. The sixth and kind of the final really positive finding for hypnosis is that it has been used effectively for some medical and psychological purposes. So it has been used to help with things like weight loss and kind of the treatment of chronic pain. And in some cases, especially as we mentioned in the first part, if the person is kind of someone who is more susceptible to hypnosis and responds well to it, then it can actually help them in some cases with things like that. So there are a couple different theories as to how hypnosis kind of comes about in producing its effects. So the first is the dissociation theory, which explains hypnosis as a unique state in which consciousness is divided into two parts. So basically, whenever we talk about dissociation, we're talking about kind of a split. And so basically, in this case, it would say that your consciousness is divided into a lower level system that's involved with perception and movement, as well as an executive system that evaluates and monitors these behaviors. So in that way, you're kind of experiencing a divided state. So basically, this theory would state that most of the mind is subject to the hypnotic suggestion, while there is one part who's kind of acting like a hidden observer. So at one level of consciousness, the individual is focused on suggestions, while at another level, they are attending to something else. So basically that there's kind of a part of you that's responding kind of almost subconsciously to the suggestions and the hypnotic kind of process, while the other part, the more kind of logical part, is kind of remaining hidden at that point. So it's kind of similar to driving. So at first, you might focus really intently on your actions. If you're driving for the first time, you just got your license, you might be really focusing on what you're doing and the steps that you need to take. But over time, you seem to drive on autopilot while attending to other things. So that's basically kind of what they're talking about here, that split between kind of your almost subconscious that's kind of continuing on with the actions as you've kind of known them to be kind of performed. While you also have another part of you that's kind of paying attention to other things. But this theory does not explain the tendency to conform to suggestions of what to expect. So it kind of tells you a little bit about why people might kind of do some of the things they do under hypnosis, but not really why you might conform to suggestions of what you should be expecting or what you should be experiencing in terms of your cognitions and things like that. So the second theory of hypnosis is the social cognitive theory, which basically explains hypnosis by emphasizing the degree to which beliefs and expectations contribute to increased suggestibility. So I talked a bit about this one on the slide with the research findings. In that first point, basically saying that the responsiveness of a person to hypnosis depends more on their own characteristics rather than the characteristics of the hypnotist. And that's basically what they're talking about here. So this theory states that the effects of hypnosis are due to an interaction between the social influence of the hypnotist, which would be kind of the social component, as well as the beliefs and expectations of the subject, which would be the more cognitive component. So this may explain reports of things like spirit possession or alien abduction, as well as cases of past life regression. So people who are kind of have more strong beliefs about those things, whether spirit possession and aliens exist, as well as whether people can kind of experience kind of past lives. Those types of expectations and beliefs that people have about those concepts would strongly influence whether or not they're going to be susceptible to kind of experience those things or talking about those things during hypnosis. So basically, people tend to conform to what they've been told to expect. So they would resist or not resist those idiomotor suggestions, so kind of telling them to either do things or not to do things, basically based on the fact they're conforming to what they've been told. So if you're told you're not able to talk and they expect that, the hypnosis is something that works and something they strongly believe in, then they're going to be less likely to talk, therefore kind of confirming that belief. So both theories do appear to have some evidence. The social cognitive may influence the likelihood of being hypnotized. So again, the beliefs you have about hypnosis would probably strongly impact whether or not you're going to be susceptible in general to hypnosis. But the dissociation theory may dictate the behavior that we kind of present while under the influence of hypnosis. So here you can see some diagrams from an older textbook that kind of, I think, portray those two theories we just talked about pretty nicely. So the dissociation theories, you can see that the hypnotist induces the hypnotic state. You get that split between the hidden observer or executive control system, whatever you want to call it, and then the rest of the mind. So you'd see that kind of the rest of the mind is kind of continuing to act on autopilot. And then you've got the person responding to the suggestions. And then in the social cognitive theories of hypnosis, you have the social influence of the hypnotist. So they're telling you you're going back in time. And then if the person has their own belief that they believe in age regression, they believe it's possible, then you've got the person conforming to what they're basically told to expect. So we won't get into any more detail about hypnosis than that. I kind of just wanted to bring up, mostly some of those major findings on it, because there is unfortunately a lot of misconception about what hypnosis can and can't do. So now we'll move on to talk about another altered state of consciousness, which would be mind wandering. So hypnosis is just the first of many altered states of consciousness, besides sleep. Obviously, we spent a lot of time discussing that one in the first module. And another example would be mind wandering, which is an unintentional redirection of attention from one's current task to an unrelated train of thought. So findings have actually indicated that we spend over 30% of our time not consciously attending to our current situation. So you may be thinking this sounds very familiar to things that you've talked about before, which would be kind of daydreaming, and you'd be right. Basically, mind wandering is kind of a more scientific term, I guess, for what we would be doing when we're kind of like engaging in daydreaming, or kind of just when we're distracted and thinking of other things. So mind wandering can unfortunately have a dramatic impact on our ability to learn, which you can probably all imagine. In studies of reading comprehension, when participants weren't paying attention to the text, they not only missed minor details, but they also could not recall major plot points. So even in cases where, they were being, say, read a story, or told, the details of a story, it was so bad, at some points that they were kind of succumbing to mind wandering that they wouldn't even be able to recall the name of the major villain in the story. So it's not just the minor details that are missed during mind wandering. In the late 1990s, they actually discovered a network of brain regions that became less active when participants performed a task. So in that case, we thought maybe those areas might be linked to mind wandering, because of course, if you're concentrating on the task and it's less active, but they're more active when you're not concentrating on the current task, then maybe those areas are kind of active during mind wandering. It might have something to do with it. So this network was kind of termed the default mode network. And it's a network of brain regions which include the medial prefrontal cortex, the posterior cingulate gyrus, and the medial and lateral regions of the parietal lobe. And you don't have to remember all that. But basically what you should keep in mind is that it was most active when an individual is awake but not responding to external stimuli. So when they're awake, they're conscious, but they're not really paying attention to kind of what's going on around them. That's when this default mode network is most active. So when they're paying attention to their internal thoughts rather than their outside stimuli. Another thing to note about mind wandering is that when we mind wander, we tend to be thinking about the future. We tend to be thinking about what we're going to do later that day or later in the week or all the work we have to do. So it could be adaptive in a way in that it's allowing us maybe at times to take our concentration away from the present and focus on the future, because that allows us to kind of better plan and prepare for upcoming events and things of importance. So finally, for this module, we're going to talk a bit about the disorders of consciousness. So your textbook discusses the case of a woman named Terri Schiavo, and she essentially underwent cardiac arrest, and at which point it was pretty severe, so there was no oxygen getting to her brain for a little while. This occurred in 1990. She was in a coma, and we'll talk about what a coma is in a minute, for about 3 months, and then her status was changed to persistent vegetative state. Her husband actually started asking in 1998, so 8 years later, to take her feeding tube out. He basically said, she wouldn't want to live this way. And unfortunately, her family disagreed, and this spawned a big legal battle that lasted for 7 years. And so this case essentially highlights the importance of consciousness in medical decision-making, because of course the degree to which the patient is conscious can really influence their diagnosis. So in this case, it was very difficult because even though she was in a very limited state of consciousness, her family was arguing, well, she's still alive, so therefore we should kind of keep her alive. And it did take a very long time for that matter to be resolved. So eventually in 2005, she was laid to rest. And so neurologists have basically distinguished 6 different types of consciousness, one which is conscious itself, so being fully conscious, and then the other 5 we'll talk about here. So the first is brain death. Brain death is a condition in which the brain, specifically including the brainstem, no longer functions whatsoever. So that's obviously the least amount of conscious, and then slightly up from that would be a coma, which is a state marked by a complete loss of consciousness, in which the patient has some reflexes, but the brainstem reflexes are suppressed. The third is a persistent vegetative state, which is a state of minimal to no consciousness. So, slightly above coma in terms of consciousness, and this, of course, was what Terry was in for the majority of her time. So the patient's eyes may be open, the individual develops sleep-wake cycles, but they still have no clear signs of consciousness. They're not able to track movement, and there is some hope for recovery, but chances decline sharply between 6 to 12 months. So in Terry's case, after 3 months, her status was changed from coma to persistent vegetative state, but of course, she remained in that state for, well, I guess almost 15 years after that. So even after the first 6 to 12 months in that state, they probably could have been pretty sure that she wouldn't fully recover. The next up is the minimally conscious state. So this is a disordered state of consciousness marked by the ability to show some behaviors that suggest at least partial consciousness. So they're actually able to kind of show some things that wouldn't be that wouldn't be possible in the persistent vegetative state. So even if it's on an inconsistent basis, they are performing some behaviors. The behaviors must be distinguishable from reflexes, so they're not reflexive. And the patients may be able to follow simple instructions or to provide yes or no answers. And the final state, which is listed kind of just below full consciousness, is a very interesting and unique state. So basically it's called locked-in syndrome. It's a disorder in which the patient is aware and awake, so they are actually fully conscious, but because of an inability to move his or her body, appears unconscious. So it's caused by damage to part of the pons, which you might remember is kind of in our brainstem, and most of these patients unfortunately do remain paralyzed. So that one is very interesting because although technically they are fully conscious, it's listed slightly below consciousness because they are unable to indicate their consciousness because they are fully paralyzed. So there's much debate, as was kind of illustrated by that example at the beginning, over when one should be removed from life support. So at what point do we kind of consider them, it's hard to put it nicely, but I guess not overly viable, and at what point should we make the decision to kind of terminate life support. And I'm not going to answer that question for you. I don't know the answer myself, but it's definitely something to think about. So here's a little diagram that illustrates those different disorders of consciousness and kind of the level, kind of the rating in terms of from like full consciousness to the least amount of consciousness. So you can see that if you start at the bottom with brain death, as you go up through the list, wakefulness or awareness kind of increases. So you go from brain death to coma, vegetative state, minimally conscious state, locked-in syndrome, and then finally, and I guess we should say persistent vegetative state there is the way we define it, and then full consciousness. So that is it for this module. We're coming in at just under 20 minutes. As I mentioned, these 2 modules are quite a bit shorter than the first. So we will end there for this one, and I'm going to pick up right away with module 3 and get that one recorded as well. And that way you will have all of your notes posted up until after the break next week. So thanks for listening, and I will talk to you in the next video.